Good afternoon. My name is Michael Yudell, and I am joining you from my remote office location. I'm normally in my office at the Dornsife School of Public Health at Drexel University, where I chair the Department of Community Health and Prevention. I am joined today by two old friends and colleagues in the field to talk about ethical issues in the context of the current COVID-19 pandemic. I'm gonna take a moment to introduce my two guests, and we're gonna jump right in. During our hour together, I welcome you to submit questions through the Q&A chat box on your screens in Zoom. And during our hour, we're gonna dive into some of the challenging issues that we're facing on both the bioethics front, particularly some of the clinical issues that we're facing and issues with patients. And then we're also going to focus on some of the broader public health ethics issues and how those are going to challenge us on issues that they already have, like quarantine, social distancing, and surveillance. So we hope you enjoy this time with us. These are crazy times, and we hope that the discussion we have here today will leave you with some things to think about as we head into what is surely going to be a crazy year. So I'm joined today by Dr. Holly Tabor, who's an associate professor of medicine at Stanford University and is the associate director for clinical ethics and education at the Stanford Center for Biomedical Ethics and co-chair of the ethics committee at Stanford Hospital and Lucile Packard Children's Hospital. Holly's research focuses on ethical issues in genetics and genomics, specifically the return of results in translation for exome and whole genome sequencing. I've been lucky enough to do some work with Holly a few years ago on ethical issues in autism research. So Holly, it's great to have you here.
It's great to be here. Thank you.
I'd also like to introduce James Colgrove, who is a professor at the Mailman School of Public Health at Columbia University in the Department of Sociomedical Sciences, where his research focuses on the relationship between individual rights and collective well-being and the social, political, and legal processes through which public health policies have been mediated in American history. James has written some wonderful books and articles on many of the issues that we're going to dive in today. And James, it's really a pleasure to have you here today. Welcome.
Thank you. Great to be with you.
So let me just start with a check-in. How are you guys doing in these crazy times in which we find ourselves?
I think all things considered, doing okay. Thinking a lot about all the people who are struggling in different ways right now, but glad to be able to connect with you and other people who are in the audience and James today.
James?
I'm doing okay. I'm joining you from New York City, and it's fascinating to watch things unfold in real time, in particular to see all of the issues that I've been teaching about for years actually confront us, not in a hypothetical way, but to actually have to deal with them. And New York City certainly is facing really all of the issues that this epidemic has raised in an extreme form. So very happy to have a chance to talk about it.
Yeah, thank you, James. And as you were saying, sort of the striking nature of what's unfolding around you most acutely and around us, as well as sort of a real-time look at the issues that we all think about in our own work, mostly as hypotheticals, and suddenly finding ourselves confronted with a real-life, insane pandemic that is reshaping our world in ways that we had hoped never to see in our lifetime in this way again, and yet we are living through them. Certainly, James, as a historian and an ethicist, there are ways in which many of these issues are familiar in a way that is uncomfortable, and from issues around asymptomatic individuals which harkens back to one of the stories that we tell in our classes about Mary Mailman and the spread of typhoid, to some of the ethical and benchside issues, Holly, that I know that you've been thinking about. So I want to dive into our discussion by asking you whether you think we are where we should be as a nation in terms of our response, given that we're now 2 months into this mess. And before we started the webinar, one of the things that we were talking about, well, two of the things we were talking about, which are related to each other, were issues of trust in the context of the pandemic, and the broader information environment, the way information is being shared both before and now during this crazy time. So I'm wondering if either of you want to share your thoughts on where we are now and how you are perceiving this.
Want to start, James? Yeah, I mean, I think we're not where I wish we were. I think I really would have hoped we'd be in a different place. And there are probably many, many reasons for that. I think, you know, there are pockets of optimism, and that's great. I think there are bigger pockets of pessimism and frustration and uncertainty. I think, you know, one of the pockets of optimism is we, this morning at our grand rounds, we had our ICU task force present some of the work that they've been doing over the last 8 weeks or however long it's been to address how to care the sickest patients in the ICU. And I think that's been a pocket of a place where at some hospitals that's gone well, and there's been some communication across the country about how to do that well, but we all know that that has not been equally accessible in all areas, and that in places like New York, where James is, they're just, you know, they've been completely overwhelmed. So I think that it's the heterogeneity of how people are experiencing this, the real, the disparities and the sort of gaps in our system that are being magnified, both our public health infrastructure, as well as our general healthcare system, and the way that people have limited access to healthcare, and the health disparities and other kinds of problems that exist underlying in society are all magnified. So we're not where I think we should be in general, and I think we're not where we should be in responding to the crisis. There are still many places that don't have PPE and don't have testing, and I really would have hoped we would be in a better place now. That said, I think it's important to try to focus on where we need to go and what we need to do about that. But I think as a more of a dilettante professor of history than either of you, or dilettante historian than either of you as professors are, I just see so many patterns coming up from history, and it's concerning and disturbing, but I think that's why it's important to have conversations like these and have people like you tell us what we can learn from the past as well.
Well, James, that's a good pivot to you, I guess. Like,
yeah.
Do you want to situate us historically in the context of the question a bit?
Yeah, I mean, I certainly agree with everything that Holly said. You know, epidemics have always had a way of exposing societal fault lines. They reveal places in society where we have failed. They reveal the sort of the crisis points of injustice and inequity, and they kind of thrust them into public view. And COVID-19 has been no exception to that in terms of our societal failures around things like poverty and incarceration and immigration and legal protections for everyone. You know, I think to your question of where we are now, we do seem to have flattened the curve mostly, and so I guess a hopeful thing or a positive thing I would point out is that this does seem to have demonstrated that social distancing works. And I think that's a non-trivial accomplishment. I think it's important that we have seen this demonstrated empirically, that the measures that have been very controversial actually can help to limit the spread. But the fact that the situation that we were in reflects, you know, many years of underinvestment in the public health infrastructure, of a lack of investing in things like laboratory capacity and workforce capacity for our local and state health departments, for the people to carry out essential functions like we'll talk about surveillance and contact tracing, and those those deficits are not going to be quickly or easily addressed. Those are deep-rooted deficits that are going to take long-term investment.
So on that note of deep pessimism, looking ahead, what are our obligations as public health and folks and ethicists to reach out both to the public, to our field, and to policymakers to change the discussion? Because, you know, I worry, you know, James, you pointed out a lot of the shortcomings in terms of public health investment over the last several decades and where that has left us and how that has left us fundamentally unprepared. As a field, has public health done enough? And how can, you know, sort of an ethical framework from public health ethics help push the field and push society back to a place where we prioritize these issues?
It's interesting. I think a lot of what helped, what I read about helping with some of the shelter-in-place orders, which flattened the curve, as James was talking about, was some of the discussion of public health, and particularly of the 1918 Spanish flu. And I think it was interesting that for some people, at least, that was sort of a framing and a motivation that kind of used some traditional, both the history of public health and public health practices to sort of frame why staying home was important, at least for a while. You can argue that maybe that's not going to work so well moving forward over an extended period of time, but it at least worked for a while. I think part of it, though, is that people will be looking to public health in a way they haven't, you know, maybe in almost 100 years, to be experts and to frame what the values and the choices are, and to frame what the length of time is over which one might or might not see results. And I was just on a call this morning with a bunch of ethicists talking about sort of competing values and how ethics can help sort of frame what some of the different values in tension are around decisions like continuing shelter in place, like some of the other kinds of public, like contact tracing, like some of the privacy issues that will come up, and how those values can be discussed and framed. And actually someone said, well, what could public health experts or public health professional organizations do to sort of be a voice on that? So I think it's a really good question. I also think there's a lot of really, you know, several of my colleagues have said that there's such a fire hose of information right now in science and academia and in medicine, you know, so many preprints happening in some of the therapeutic spaces, the vaccine spaces. But I think that it may be one of those times where engagement with the public and sort of communication of science and public health to the public through things like op-eds and through things like other sort of more publicly facing kinds of conversations may actually be more important than ever. And that people are paying attention more. I mean, obviously not everybody is paying attention equally, but that more people are paying more attention to these things. And so I think it's actually a really unique opportunity for people with different backgrounds and perspectives from public health to share that publicly across different kinds of platforms to talk about that and to talk about the trade-offs that public health experts are familiar with.
Mm-hmm. Right, never let a good crisis go to waste. I mean, this is a perfect opportunity to talk about ethical concepts in a way that people will immediately grasp because they're living through them. I mean, I think the crisis has really, one of the things it's shown is the critical importance of effective public communication and how much sort of the science of communication, you know, there are schools of how do you communicate effectively. I think public health as a discipline really needs to incorporate that into their work. And historically, that's certainly always been true. The kind of the public messaging has been key to securing public trust and cooperation. I mean, I think here, you know, in New York, Governor Cuomo's daily lunchtime briefings are required watching now, and he's really shown himself to be a master of sort of metaphors to make things concrete, and how do you be reassuring while at the same time acknowledging uncertainty. I think he's in some ways been a model of effective public communication.
Yeah, and I think, can I say one more thing, Mike?
Yeah,
I think
ahead,
the other thing about communication is there was a wonderful piece, or I thought it was good, in the New Yorker about the history of the EIS the Epidemiologic Investigation Service, and talking about public communication, about public health, and sort of the practices that have been established by the EIS, and sort of the ways in which some people like Cuomo and colleagues may be following some of those best practices, and other organizations and government officials are not. And it was a very nice article for people to, in your audience, to know about and to share. But I think that the other really interesting thing about communication that I've found, both in a lot of private communications I have with people and sort of publicly, is this idea of the cognitive biases that go into thinking about public health, and about the trade-off between autonomy, non-maleficence, and beneficence. You know, as Americans, we're used to being able to want to be able to go where we want to and when we want to, and to be able to have the right to go to work and all those other things. And that, you know, again, James and Mike can say more about this than I can, but historically there's always been a tension between those freedoms that we sometimes take for granted and public health imperatives. And it's how to approach what do we know about cognitive psychology and cognitive biases, particularly in this information age, that we can use and leverage in the way we communicate to convince people to do things that their natural instinct is not to want to do, even if up here they understand some of the reasons. The cognitive instinct is to want to do the opposite. And I just think that's a really interesting idea, that the new information age has changed a little bit.
So I want to just push on that point for a second, and then want to push a little bit more on this tension between public health and civil liberties. So first, James, you were talking about folks tuning in to Governor Cuomo, and he's on CNN, and his briefings are covered nationally often. Where do we as public health academics, as scientists, fit into that? Like, we are deferring to politicians, and Holly, I know you mentioned op-eds, but are we missing the boat in not being those voices out in front, and then waiting for a pandemic to happen for the politicians to, in some cases, speak our language, and in other cases, if you look at, you know, states that are opening up right now, ignoring public health experts, you know, not paying attention to us. So what's our responsibility in this moment, or what was our responsibility before this moment that we might have failed on?
Yeah, it's a really interesting issue with that the public health as a field has grappled with for really since its founding. Are public health professionals scientists? Is what they do sort of pure science and knowledge generation, or do they wade into the messy world of politics and policy? And I think as a field, we've seen there has to be room in the profession for both of those kinds of activities. Public health, the idea that public health can be sort of purely apolitical enterprise is a fallacy, because public health has to be based in the most rigorous science, but it has to be implemented in the political sphere. And so there have to be people in public health who are prepared to be good at public communication and to advocate for policies that the science points to and supports.
Well, and I talked about that a little bit in an op-ed I wrote about moral courage in the time of the pandemic. And I think part of this, for whether it's public health academics or public health, you know, agency leaders, and for scientists and physicians, is what does it take to say what you think we think about a situation with courage, particularly when there's pressures to not say it. And I think, you know, sometimes those stories get told as someone being, you know, there was a story of one of the doctors in Wuhan, I believe, who sort of initially talked on social media about the crisis and was sort of silenced by the Chinese government there. So there's sort of these sort of heroic stories, but I think they happen in less dramatic and heroic ways too, in the ways that people can stand up and say when they're concerned about things, ask questions about things, ask why certain questions aren't being asked. And I think that's sort of incumbent upon all of us. I live in Santa Clara County. That's not quite true. I live in San Mateo. I live just over the border into San Mateo County, but I live next to Santa Clara County, which is the county in California that's been the hardest hit. And Sarah Cody, who's the head of the Department of Public Health in Santa Clara County, was the one who sort of started the movement to put the more restrictive shelter in place in order in the Bay Area that led to Governor Newsom eventually doing it early in California. And she's, I think, done a very good job of being out there, doing daily briefings, getting out a lot of information, being very much the public face, following some of the things that were described in that EIS article in terms of practices. And so I think there's also sort of this Venn diagram of intersection between what the public health government officials are doing, even on the local level or the state level, and what the sort of people in public health academia and medical academia need to do, and in medical practice and clinical care need to do as well.
All interesting things to continue to think about, but I want to shift gears for a second because we're already 20 minutes into our hour-long discussion. And I want to get back to the civil liberties discussion when we talk about surveillance a little later. But Holly, I want to turn to you for a moment and talk about, some of both our ethical obligations and clear ethical failings already, 2 months into this, in terms of how we are protecting for and caring for healthcare workers on the front lines of this. We've spoken about PPE shortages, concerns about ventilator shortages, mental health support. What are you seeing in your role, and what are some of the concerns that are really worrying you these days?
Yeah, and I mean, I think like many of us, I have a particular vantage point, and I don't pretend that my vantage point covers other people's vantage points. And to James, I'm not in New York, and I'm not in the Navajo Nation, which I've been reading a lot about, and other areas, Detroit, other places that are really hard hit. But I think the things I've been worrying about in my role and my hat, I've been very involved in working with our colleagues in clinical care to think about how we can develop and think ethically about things like our crisis standard of care policies, which need to be implemented when the governor declares a medical emergency for things like triage of scarce supplies like ventilators if we were to get to the point where we didn't have enough ventilators. And I think that's, the National Academies of Medicine issued a report about this. I can't remember the exact year, I'd have to look it up. But a lot of hospitals and institutions came up with these policies after that National Academies report and after Hurricane Katrina and after H1N1, but nobody really envisioned this situation. And I think one of the things that's been so interesting is the way in which the discussion has evolved over the last month or two about what the shortcomings are in some of these policies, what some of the inequities are, particularly towards people with disabilities, and how we can write these policies in ways that are fair and just, and the ways that we don't unintentionally or maybe even sometimes intentionally reify biases and inequities that exist in society. So a lot of it has been planning for the worst case scenario and trying to be as ready as we can to be as fair as we can. That's also happened with things like visitation policies. There's been a lot written about that. We've obviously had to really cut back on, and in some cases eliminate visitation for many patients. That's made it really hard to do shared decision-making around goals of care, not just for COVID patients, but for patients who have other kinds of conditions where you really need to be able to have conversations with family members, not just for emotional reasons, but for decision-making reasons, need to be able to see their loved one in the hospital and see how they're doing. I think there's been a lot of great efforts in hospitals that have the resources to try to move that to telemedicine and video chat and other kinds of things. I think that's a wonderful development, which will be good for medicine when and if we all get out of this, because it will actually equalize access for some situations. But it makes it really, really hard. And when do you make exceptions? When do you make exceptions for pediatrics? When do you make exceptions for people with cognitive or developmental disabilities or people who are dying? And I think that's been really, really hard on our institutions. I think as testing, we'll talk about testing later, but as testing comes online, do you ultimately, if you have enough tests, which granted we don't yet, do you test all your visitors? What do you do if people refuse testing? So those kinds of issues. Do you test all your healthcare workers? What do you do about those things? So that's one set of issues. I'm worried about the shortage of PPE. I mean, I don't think anyone who's in this area hasn't. And I think, there's these issues about the ethical obligations of providers, should they go in if they don't have protection? And I think some people have made compelling arguments that you do not have a professional obligation, at least at some threshold point, and it's a question of where to risk your life. And so how do you balance those things, and how do providers struggle with the moral distress that comes when they want to do their jobs? I've also been spending a lot of time at our institution working on debriefings around moral distress with providers of different kinds, and talking about what it's like to go through this, and how they're balancing some of the stressors they have at their bedside care with their sort of institutional stressors and their fears and their personal lives and the upheaval they're having in their personal lives, and how all the traditional mechanisms that we've had to sort of cope with moral distress, distraction, things you like to do, seeing friends and family are gone. And so how do we support each other in these times so that people don't completely burn out? I think that's a really important issue for ethics in medicine as a whole. And then I'm really interested also, just the things I'm thinking about are the disparities, and what we do about that, and how it's not a new problem, but it's an exacerbated problem, and we can see it more pronounced and in a more pronounced way. And I've been talking with a lot of people about that, and I think they're deep systems issues, but how do we use this opportunity to kind of rethink the way we do things? I think, like telemedicine, like this opportunity has caused us to really rethink what we're willing to do for telemedicine. We can rethink some of the other things we do too, in both small and big ways. And so I've been trying to think a lot about that as well. The other thing I'll just mention briefly is research. I don't know if we're gonna have time to talk about this, and I'm not as involved in it as other people, but I think there's two issues. One is the sort of proliferation of COVID research and how we think about clinical trials and other kinds of studies, but also what research isn't getting done. I think there are a lot of people who count on cancer trials, on studies of rare diseases, other kinds of things, and are really have hope and optimism, and sometimes even have therapeutic needs from those research studies, and they're not happening in the same way across the board. So if this is going to go on for some time, as I think most people expect it will, how do we balance those benefits and risks and think about what to do about that?
Well, that was a lot. So that's okay.
Just that, that's all.
I want to break down a few things. One, I want to get back to the obligation of healthcare workers to provide, whether or not healthcare workers have an obligation to provide care in a context where their safety is being undermined, either through shortages or in other ways. And we've seen this in the news, and this puts frontline healthcare providers under tremendous stress. And we've seen a little bit come out on this in the last week, but I'm wondering if one of the biggest long-term challenges coming out of this is going to be the impact, the mental health impact, particularly on frontline, never mind, it's going to impact all of us, but particularly on frontline healthcare workers. And, what, from your perspectives, should we be thinking about and considering on that front?
Yeah, I mean, I think it's also not separate from the fact that our healthcare institutions are having significant financial crises right now. And so many of our institutions are also, including mine, are seeing cuts to their healthcare workers, whether it's cuts in salaries or furloughs or actual layoffs. I mean, I think we have an obligation to keep our healthcare workers safe in order for them to do their job. I think the challenge is, what is the definition of safe and who gets to define that and enforce it? I think the other hard thing is, just because you have a right to a certain level of safety as a healthcare worker doesn't mean that the risk to you refusing to do it isn't that you'll lose your job. And so I think a lot of healthcare workers feel this understandable tension between what they think their duties are, what their sort of deontological framework is for thinking about what they're obliged to do to their, because they signed up to be healthcare workers, to their patients and wanting to serve their patients, and their sort of risk to self and to life and to their own safety. So I think a lot of my colleagues are really struggling with that. I think on an institutional level, one thing that a lot of my ethics colleagues are trying to do, as well as my anesthesia colleagues and other people, is trying to raise the alarm for institutions to really take more of a lead in determining that we will require certain levels of PPE in order to have people take care of people. But that's easy to do in an institution like Stanford or Columbia or Drexel. It's harder to do on the Navajo reservation in the hospital there. It's harder even arguably to do at the VA in some ways. So I think there's not, unfortunately, I don't know one right answer of this is the protocol to follow if you're concerned it's unsafe because you don't have PPE. I don't think we have that, but I do absolutely think it's an ethical issue that we cannot provide even what most people would agree is the minimal level of protection in some places still to this day. And I think it's one of the most shameful aspects of this is that in the how many weeks has it been now? 8 weeks. We've been doing 7-8 weeks. We've been doing this, that we still haven't solved that problem in this country. So that is one of the things I worry the most about.
And just to really underscore that, I mean, to come back to your original question, Mike, about the duty to care, you know, the healthcare provider's duty to provide care has implicit kind of reciprocity, right? That yes, they have a duty to care, but that the systems within which they work have a duty to fulfill their ethical obligations to the care providers and to provide care to them of all kinds and the supports needed for them to do their work to the extent possible.
And also to that, oh, sorry, go ahead, Mike.
Go ahead, Holly. Finish your thought, and then I want to push on one more point.
I think part of our obligation is how do we, I have a colleague yesterday who said this to me in a conversation, how do we think of what's the sort of most extreme situation we have in any of the elements of what we're talking about? So what's the situation that has the worst PPE? What's the patient who has the least access to COVID testing or COVID care? You know, what is the sort of extreme, I don't want to say user, but, you know, target, and then figure out what small and large things we can do to work on that, you know, and not make it all a yes, no, we fix it or we don't fix it. I think even small things are better than nothing at all. But I mean, if we only focus on the easier cases, we won't really deal with the most challenging situations. And so I've appreciated the coverage of the situation in some of the tribes, the Navajo Nation. There was some on the Lummi Nation in Washington earlier this week, because I think that is one of the situations that's really bad. And I think with the PPE, some of the coverage of some of the hospitals in New York that really did not, and I saw one about Massachusetts as well, that really did not have adequate PPE, were a way of shining a light on, no, we have to solve this problem right here, this extreme problem right here. And I don't have good answers, but I feel like focusing on those extremes is kind of what we have to do.
So I want to sort of bring this all together to get back to a point that both of you made earlier about disparities. And, you know, health disparities are an issue that public health has been addressing since the 19th century. This is not a new set of circumstances. And, you know, over the last 8 weeks, we've seen a lot of focus on how outcomes and access to care and outcomes for care in terms of morbidity, mortality have been focused on how different communities have had very different outcomes, how Black community across America has suffered disproportionately, especially in cities like Detroit and New York, and Latino communities as well have suffered, and Native communities, as you pointed out earlier, across the country have suffered. Public health talks a lot about these issues, and I wonder, you know, what is the accountability going forward to make sure that these issues receive more than lip service, that we do more than just measure these differences in outcomes, and actually, this gets back to our politics discussion from earlier, like, what is public health going to do to move beyond measuring disparities to actually changing outcomes in a really significant way? And again, we continue to defer to the policymakers and politicians on this front, but we and the communities we work with are the bearers of this knowledge and the impact of these outcomes. And I feel like as a field, we have failed communities for too long. And what do we do coming out of this? Because, you know, when things get back to relative normal, the public will start to forget the fact that certain communities suffer disproportionately in this pandemic. How do we make change? What are our next steps?
Well, you don't love softballs. I think you.
And I also want to give credit to some of the folks out in the audience who've been pushing me in the question box to push on this question. So
great questions. Great question.
You articulated a very compelling argument for why public health as a field needs to include political leadership and communication leadership. And I would add, I think in particular that academia really needs to step up. The folks who run city and state health departments on the front lines are appointees of the executive branch. And so in many cases, their ability to advocate for the policies that they might favor are really constrained by the executive to whom they report or to the legislature on whose funding they depend. And so I think, this is where academics who have more freedom to take strong controversial positions and advocate for what they think need to be done really need to step up and make those arguments.
Yeah, I would add that we just got a comment from Melissa Gerber who says we need to talk about racism because that's one of the fundamental pieces of this that, again, we talk about this in public health, but translating that to the public in a way that is meaningful and makes change is something that I think we would all agree we have failed to do.
Well, and I was on a call recently where someone was talking about the values issue again and was saying, we need to not make it about politics. So let's leave politics out of it. And, as an amateur historian, I sort of feel like that's not possible or maybe completely ethical. I think public health, as you said, Mike, in the beginning, requires policy change and is based on sort of structural inequities in society, and that is inherently political. And I don't see how we get out of this without a real shift in funding and in priorities and in values and stating why we think the way we're doing it is not working. And it's never been more stark. I mean, I think it has been stark for some times in some ways, but it's more stark to more people now than maybe it was before. And I feel like this is as important a time as any to call, as Melissa said, to call it out for what it is and to really argue for shifts in priorities that require policy change, which are inherently political. I realize that's maybe not always popular to say, but I think health. Anyone who thinks health and science aren't political and don't have politics in it, I think, is deluding themselves.
So, and Mike, you emphasized inequities in clinical outcomes, but I think the racism certainly extends well beyond just the well-documented disparities, the health outcomes disparities. They certainly extend to the issues of social distancing and the kind of the intersections between social distancing and community policing. Absolutely, we've seen this in New York City and the unequal enforcement of social distancing measures. We see this in the stigma and the racism surrounding the supposed connection between COVID and Asian American populations and Asian populations in general. And so I think it really, the pervasiveness of the racism and the epidemic is, as what we talked about at the beginning of this revealing these deep fault lines, is shining a light on all the forms of racism in our society.
Yeah. This is a very important piece of our discussion. I suspect that some of it will get picked up on the webinar we're sponsoring next week about COVID and human rights. So please consider tuning in for that. I want to shift gears to talk about testing. I think that the pit in my stomach that I wake up with every morning is the fact that we are now more than 2 months into this, and we remain stuck in sort of quasi-lockdown because testing capacity, although improved, is still not at the point where it needs to be for us to, be able to relatively safely re-engage in our public lives. And testing brings up a host of issues and challenges going ahead as well, which include, will mandatory testing be a part of access to certain parts of society. If we want to go to group events, will we be tested before that happens? Will we be tested at, going into airports? And will we be tested periodically in the workplace? And, ethically, Holly, what are some of the concerns that you might have in situations where testing becomes mandatory, or is there a justification for such measures, as, again, minus all of the frustration and rage that we all feel for the fact that we're still sitting here without adequate testing, that we will be there eventually, we hope.
Yeah, I mean, I think part of it is even if we had enough tests, which I do hope we'll get to that point, the meaning of the test, both the literal or biological meaning of the test and the social meaning of the test. And I think, I've heard a lot of talks about the tests, about the viral tests, about the serology tests, about people testing positive, then negative, then positive, about people having, virus detected, 2, 3, 4 weeks after they seemingly have recovered, people being asymptomatic, all these things. So I think problem number one is really understanding what the test is. And you guys know, I've talked to you about this, that I did some work when I was an undergrad on diphtheria testing, and how first they tested for the bacteria in the throat. And there were a lot of people walking around with the bacteria who were never sick, but who were transmitting it. And then they tested for whether or not they just gave antitoxin out to people in populations to try to confer immunity to people. And then they eventually did the Schick test, where they measured antibodies to the diphtheria through a skin test. And so I think there's a lot from the history of medicine on testing that will teach us about that. But I think you're right, Mike, that one of the things that will happen is, who are the gatekeepers? When will you be asked to be tested? I have a friend who lives in Shanghai, and in China, they are already implementing this, but they have the very different situation of being a state and a culture in which a sort of a very authoritarian structure in which testing gets administered is not alien to most of the population. And so I think the first place this will come up is in testing when you need to go to the doctor, when you need to get an elective surgical procedure done, when you need to visit people in the hospital. But I think you're right, it's going to become testing and regular testing for other kinds of, school, airport, travel, other kinds of things. And I do worry about it, and I worry about it being used again to exacerbate structural inequities and disparities in our society, that not everyone will be able to get access to a test, and that some people's test status will be misinterpreted or potentially distorted, or we won't care about some people's test status. I think someone in your comments, Q&A, said something about, the inequities between who's an essential worker and who's not, and that a lot of the people feel like their lives are being devalued because they feel like that no one cares whether they have PPE and whether they have to go in to wherever their workplace is that they feel like they have to go to. So I think testing, I would like it to become a public health commodity that's regulated by the government and by public health systems, and not by the open market, and done in a fair and equitable way. I don't know that we're that close to that in America, and I don't know how we're going to get there.
Testing is not going to save us. I mean, I think that there are clearly some uses for which it is absolutely indicated and necessary. I think people are often looking to testing as a kind of magic bullet that's going to solve all of these other problems that it just, even if we lived in an authoritarian society, it just practically the issues of sensitivity and specificity, it just to implement this on a wide scale would be completely impracticable.
So what is practical then, James? And I'll turn to you, given your expertise, particularly on issues of surveillance, and both historically and today, and that tension that we spoke about at the outset of the call, and that some of the questions have been, touching on, which are the civil liberties issues. So, what are the next steps that we take as a society to protect ourselves, and how do we use public health surveillance to protect us as much as possible?
Yeah, I mean, this is really, I think, one of the central questions that we're grappling now with, looking at a kind of new normal of the possibility of having to maintain social distancing in the absence of a vaccine or a treatment, and with continued community spread. At Columbia, we're now in the midst of grappling with how we bring thousands of students back to campus potentially into classrooms where they're sitting next to each other. And clearly that's not feasible for the foreseeable future. Surveillance is an essential tool of public health. Surveillance is the eyes and ears of public health. We can't do our work without surveillance, but there are historically have been issues with privacy and confidentiality and the uses to which the data gets put. These, I think, are particularly critical with respect to immigrant populations and other populations who are facing risk of legal jeopardy should their status be known. I've been reading a lot about now proposed partnerships with Facebook and Google to track movements through cell phone data. I don't think Facebook and Google are our friends, and I think I'm very concerned about mechanisms of oversight and accountability. And I think some of the scandals that we've seen with data sharing should make everyone uncomfortable about the prospects of private sector entities becoming involved with surveillance. That said, surveillance capacity in public health is one of the longstanding deficits in our public health capacity that we need to address. The ability to have better reporting systems in place to track the spread of disease and to identify hotspots and community spread.
So, do you foresee in your vision the ability to contact trace without relying on some of these technology companies, given what's going on globally with some of the cell phone technology? Would you rather us avoid that? How do we do this? Because if we use any type of cellular technology, there's a corporation involved. Mm-hmm. Even if we avoid Google and Facebook somehow, what are the compromises that we might have to make in this context with our privacy to preserve public health, or is our privacy more important in some cases?
Mm-hmm. Yeah, it's a classic kind of ethical conflict in public health ethics, going back to the origins of the field, the tension between the duty of the state to act in a beneficent way to protect the common good, balanced against the needs of individual autonomy to maintain a sphere of privacy. And striking that, there is no easy answer to striking that balance. You have to, I think, take it on a case-by-case basis.
Holly, anything you want to add to this piece of our discussion?
Yeah, I think that also someone in your Q&A talked about whether we can force people to take tests or force people to give treatments, which is similar, I think, to forcing people to give up, not exactly the same, but has some parallels to what other data we can force people to share through some of the companies that you're talking about. And I think historically, there certainly have been instances where we have either forced people or effectively forced people to do treatment and to do other kinds of public health measures or quarantine. To the answer, can we? I think the answer is we can. I think the question is, will the public tolerate it, and should we under certain circumstances? I think in our hospitals, we are starting to talk about how if someone refuses a test, we may in many circumstances decide that if their care isn't emergent, that we will not be offering the treatment, and that's to protect our other patients and to protect our healthcare providers. But obviously there are some situations where people need life and death care where we will just have to act like they have COVID if they refuse a test. There will be consequences to that as well. So I think we will be in a constant state for the next year at least of doing these trade-offs in our head all the time on a micro and a macro level with policy about how much we're willing to override people's individual autonomy about all sorts of things in order, ideally, not just for their own good, but for the good of society. And someone else asked if we're going to become more collectivist in the chat. And, I think sometimes I hope so, but I do worry that the tension towards becoming more individualistic and less collectivist is there as well. So I think it's going to be an ongoing tension on, again, both an individual and a societal level in ways we've never seen before, so starkly anyway.
I mean, there certainly is, I think, a strong ethical justification in some circumstances for compulsory and coercive health measures. I think even the most hardline civil libertarians would say that in some cases, if there is a danger to the community or to other members of the community, that we are justified in limiting people's liberties in a variety of ways, the most extreme being things like detention, mandatory quarantine, either in a hospital or a home. And that's something that we have plenty of historical experience with, often not very good lessons that we learned from history. You mentioned at the beginning Mary Mailman, which many people may not know by her more common name, Typhoid Mary, who was locked up in a hospital for 23 years in the East River in New York City. In the 1990s, New York City had a very severe outbreak of multi-drug resistant tuberculosis, and a cornerstone of its control approach was long-term hospital-based detention in 2 locked hospital wards. And it was only a very small number of patients, and they had right of appeal and various due process safeguards in place for that.
And these were non-compliant patients.
These were people who were persistently non-adherent and were considered to be at risk for spreading an airborne, quite contagious, quite deadly disease. And, those are the extreme cases. I mean, I think we have to remember that those, coercive approaches should never be our first line. They should never be sort of, we always want to look for the least restrictive alternative, and to, whenever we can, use persuasive voluntary measures and count on people's sort of basic goodwill and good ethical impulses, and sort of retain for narrowly defined extreme cases the use of more coercive measures.
So we've got about 8 minutes left, and I want to touch on 2 final points and integrate also some of the questions that we didn't get to from the audience. James, you've written a lot about vaccination, both historically and today, and we're, until 2 months ago, we were living in this strange moment where vaccine hesitancy and vaccine resistance were becoming a, part of our socio-political culture. Will that change in the wake of this? Are these individuals who are going to be marginalized if a vaccine turns out, well, A, if a vaccine is produced successfully, and B, if it turns out to be the magic bullet to get us out of this mess? What's going to happen? Are those same voices going to continue to maintain that type of resistance and disturb, that public health balance? Or will we see a shift back to, an understanding of the fundamental importance of vaccination in public health and in our lives?
Yeah, I mean, that's certainly something that we are keeping a close eye on as we race to find a vaccine. One thing I think it's important to remember is that in spite of all of the noise that anti-vaccination activists make, there is overwhelming public support among for vaccination, and polling consistently reveals this, that most people believe, in fact, that vaccines are safe and effective, and they support very robust measures to assure high levels of vaccination. That said, I do think that we are at a very precarious moment of introducing a new vaccine where all eyes are going to be on its safety, and where you can be sure that any instance of an adverse event, for example, will be seized on, and anti-vaccination activists will try to make hay out of this. Some of our listeners who are older may remember in 1976 the whole swine flu debacle, where a vaccine was rushed into development. It turned out to be associated with an elevated risk of Guillain-Barré syndrome, a rare neurological disorder. But interestingly, the polling after that episode showed that people actually distinguished between the vaccine, the new vaccine that was rushed into the market, and other well-established vaccines. And it did, the episode, which got a lot of bad publicity, did make people become less likely to receive the flu vaccine, but it didn't have any effect on their support of MMR or DPT or the other well-established childhood vaccines. So, you know, I think that's a big question mark right now. And again, I think it'll come back to the ability of the people who are rolling out the vaccine to communicate very clearly and effectively about what is known about the vaccine and what it can do and what it can't do.
Holly, anything you want to add to that point?
No, I agree with all of that. And I think that discussions like these are really critical to sort of teasing out these issues. And you know, again, the talk I went to this morning was about how to practice evidence-based medicine when the evidence changes every day. And I think this goes for public health too, that what the challenges are and what the options are for meeting those challenges is changing every day. And so we have to keep having these conversations and try to figure out how we can act.
Yeah, and as much as that makes sense to us as scientists and academics, I think the public really struggles with the changing nature of both clinical and public health messaging that's, you know, evidence-based, and the evidence is shifting, and our understanding of this disease is evolving, and with that evolution will come, you know, different ways to understand and look at policies that are meant to protect us. I want to get in the last couple of minutes we have to a few of the questions. And there's a question from Victoria who asks provocatively, which is a worse infringement on rights, the nationwide lockdown or the government's failure to prepare for what was coming our way? We know, you know, all of the national security briefings that have now, at least the general gist of them, become public, that the president and his team were warned that this was likely to be a pandemic that would, you know, move quickly through our population. You know, what do you guys think? It's a bit of a loaded and leading question. But
I think the question has its answer embedded in it. I mean, I think, you know, we in this country are very conditioned to think of rights as sort of negative rights, as like freedom from. And we are, I think, less inclined to think in terms of positive rights, of the freedom to do things that sort of robust social support, social safety net, robust government that is invested in doing good for the society can produce. So I basically agree with what I understand to be the questioner's point. I think. Yeah.
Holly, anything you want to add to that?
No, I agree. And I think going back to one of the other comments in the Q&A about collectivism versus individualism, I mean, I see this on a micro level with individual patients in the hospital that I still get consulted on who don't have COVID. I think we're having to each think about what we considered to be our quote unquote rights differently now. And that will manifest differently. There was a really moving New York Times article, I think on Sunday, about a family who the grandmother had COVID and was dying, I want to say in New York. It was a really well done article, but I think it talked about all the things that have changed now and are changing. And I think I agree with James that we're used to thinking about rights in a certain way, and we're going to have to think differently about those now. And maybe, you know, I in no way think there's nothing good about this, but I think the opportunity to rethink the things we have in our systems that are not working could be a sort of byproduct of a very bad situation. And so I'm hopeful for that. I try to be hopeful for that. It's hard to be negative about the prospects of things all the time, but I think all the comments in your Q&A are spot on, and I wish I had more answers. But I think we're all partly counting on the next generation coming up too to help us brainstorm and think about how to address these issues.
So we've got about 1 minute, and I'm wondering if there are any closing thoughts you want to share with the audience before we say goodbye. Anything?
I think so, if you want to advance public health, you should vote. That would be my closing thought.
And by mail, if possible.
Yes.
Well, we've had a fascinating hour covering a wide range of topics in bioethics and public health ethics as they relate to the current coronavirus pandemic. It's really been fascinating to sit here with you, James, and you, Holly. You know, we've known, I think I've known both of you for 20 years, and we've had lots of discussions about the work that we do, but none quite like this. And I hope that a year from now, optimistically, we can sit down and talk about lessons learned from this. That may be on too accelerated a timeline, but let's try to be optimistic. And that you two continue to stay safe and continue to do the important work that you both do in the areas of ethics as they relate to this issue in the immediate time, and given all of the other very important work that you both do. So thanks to you both. Thanks to the audience who joined in. We had a large group listening to us and some great questions. Thank you to the folks who were able to send us questions. We tried to get to as much of your questions and weave them into the discussion as we moved along. So thank you and have a good night.